Welcome back again. This is lecture number 3, and in this lecture we will discuss different aspects of prolactin, its structure, how it works, its mechanism of action, its function, and its regulation. We already discussed some of the aspects of prolactin, so we'll build up here and give you a little bit more details. So this should be really an easy lecture for you to follow. That's prolactin. That's some of the properties of prolactin. It's a polypeptide or a hormone synthesized and secreted by lactotrophs, which constitute about 15 to 20% of the pituitary gland ovulation. Usually the level of this hormone in response to estrogen during pregnancy is elevated. Prolactin usually is much higher in the females than in males, and still we don't know its role in the male. Plasma concentration of prolactin usually exhibit circadian rhythm, its highest during sleep and lower or lowest during the daytime. So there is a rhythmic secretion or some sort of pulsatile secretion. However, usually during pregnancy this may change due to suckling and breastfeeding. Just want to review with you the mammary gland here so that you understand how prolactin works. This is the breast here, and these are the ligaments, and this is the fatty tissue, and this is the pectoralis major. And within the breast we have lobules here, and these lobules actually are composed of alveoli, or within the lobules we have alveoli, and these alveoli contain the secretory glands which synthesize milk. So if you look here, this is an exocrine gland. We have the secretory cells, they are epithelial cells in the mammary gland, and these are the ones actually which synthesize and secrete the milk. Now their activity is under the control of the prolactin. Also within or surrounding this gland here is the myoepithelial cells, and these are smooth muscle cells. Once they contract, they squeeze the milk, and the milk which is squeezed will go through the duct system of the breast, and it will be sucked by the baby during breastfeeding. So the myoepithelial cells, to contract, another hormone must be present. In other words, contraction of myoepithelial cells is also under the control of another hormone. This hormone is the hormone oxytocin, which I'm sure you know where it's coming from, the posterior pituitary gland. And now you can see here, if you want to go to the details of the structure, these are the lobules here, and then we have the lactiferous sinuses, and then the lactiferous duct right here. And I'm sure that you will learn more about the details. The bottom line is we have an exocrine gland here, composed of epithelial cells, secrete and synthesize milk under the influence of prolactin, surrounded by myoepithelial cells, and these are smooth muscle cells. They contract in response to oxytocin when it is released during breastfeeding. This slide summarizes the action of prolactin, breast development, including growth and development of the mammary gland tissue and duct proliferation. And of course, the growth and development of the breast is increased by estrogen during pregnancy. To stimulate milk synthesis by stimulating glucose amino acid uptake by the mammary gland. It may stimulate some enzymes, lactogenic enzymes, which are involved in the synthesis and the production of the component of milk. And the milk actually, or within the mammary glands, the milk contains the protein beta-casein, alpha-lactoalbumin, milk sugar, lactose, and milk fat. So it's really rich. And also since it is increased during pregnancy, it inhibits the release of growth gonadotropin releasing hormone. And this hormone, if you remember, it stimulates the pituitary gonadotropes to release FSH and LH. And these hormones are important for our reproductive functions, and they are important for spermatogenesis in the male and ovulation in the female. And one thing to remember, we have just mentioned this is not a function actually, this is an abnormality, an abnormality where if you have hypersecretion of prolactin due to pituitary adenoma, it will suppress the release of GnRH, and that's why we have a failure of lactating women if it occurs. And it also cause infertility in the male, because by inhibiting GnRH and FSH, LH are not released, spermatogenesis will fail in the male as well, and it could modulate reproductive and parental behavior. It could, all hormones do. Now, this slide describes or summarizes the effects of prolactin on the mammary glands, and it also described its regulation by the hypothalamus. And as you can see here, this is the hypothalamus, this is the anterior pituitary. You already know that dopamine release prolactin inhibitory hormone, which is dopamine, and thus prolactin secretion by the pituitary gland is under constant or tonic inhibition by dopamine. When suckling occurs, apparently, a signal reaches the hypothalamus and stops the dopamine secretion, and thus we release the inhibition from the pituitary gland, and the pituitary gland will start to release prolactin. Now, once the prolactin is released and its level gets high in the plasma, it will go back and cause feedback. But you have to watch this. I mean, look at this. We usually say, well, the hormone will inhibit the secretion of the hypothalamus. But here, because the hypothalamus releases an inhibitory hormone here, so when the prolactin's level are increased, it goes to the hypothalamus and actually decreases dopamine release, and dopamine will inhibit its secretion. So there is a slight difference here, and here are the functions on the mammary gland: development, milk synthesis and production, stimulation of lactogenic enzymes, which are needed for the milk synthesis, milk protein synthesis. It could cause breast differentiation, duct growth and proliferation and branching, as well as glandular tissue development. So it basically affects all aspects of breast development. And now the main release for prolactin is suckling. So when suckling occurs again, the hypothalamus will get a neuronal signal, stops dopamine release, and the prolactin will be released. So that's really slightly different from other systems. That's again here, you have suckling. We have mechanoreceptors in the nipple. They are carried by mechanoceptive neurons or by tracts which carry the mechanoceptive sensation. Somehow they reach the hypothalamus. I don't know if the details are known. And then once this signal, the suckling effect or the suckling signal reaches the hypothalamus, it inhibits the release of dopamine, or decrease prolactin inhibitory hormone, which is dopamine. I am not sure about this one. It could be increasing TRH, and then once this happens, the release of inhibition from the inhibitory effect of dopamine will stimulate the anterior pituitary gland to release prolactin, and the prolactin go and induces milk synthesis. Now there is another pathway which is important for lactation, which is known as the milk letdown reflex or milk ejection. This is also a neuroendocrine reflex. You have suckling in the breast. It will stimulate a nerve pathway right there. And then it goes to the posterior pituitary gland, stimulate the release of oxytocin, particularly from the paraventricular nucleus. Oxytocin will travel and reach the mammary gland, and it will cause construction of the myoepithelial cells and cause milk ejection or milk letdown. So one hormone, prolactin, is for synthesis, the other hormone, oxytocin, for milk letdown. Now, the control of prolactin, as I mentioned, is usually under tonic inhibition by dopamine, and apparently dopamine interact with dopamine D2 neurons, they are called. D2 inhibition of lactotrophs of prolactin is mediated by D2 receptors through J protein coupled receptor. J alpha I means it stimulates the adenyl cyclase and the formation of cyclic AMP. So it acts through the J protein coupled receptor, the stimulating type. This will lead to the activation of cyclic AMP, adenyl cyclase. Adenyl cyclase will form cyclic AMP, and then cyclic AMP will do the rest of the job in terms of gene expression, enzyme synthesis, protein synthesis, etc. It is, as I said, the primary stimulus for the release of prolactin is suckling of the breast during lactation, and increase the level of steroid hormone, primarily estrogen, during pregnancy. The neuronal reflex of prolactin secretion is basically mediated by the degrees of the tonic inhibition of dopamine on lactotrophs. So inhibition of the inhibition will lead to excitation. We talked about this. Estrogen stimulates growth during pregnancy, as well as prolactin gene expression and release. And remember, because apparently it upregulates prolactin receptor during pregnancy. Now, TRH, as I mentioned, has been identified as a potential prolactin releasing factor. So it could be there. So there is a possibility that we have a prolactin inhibitory hormone, which is dopamine, and it's possible that TRH is a prolactin releasing hormone, but it has to be present at high amounts. This slide basically summarizes the factors which cause an increase in prolactin secretion: estrogen during pregnancy, breastfeeding and suckling of the nipples, sleep, stress, and possibly TRH. Factors that decrease prolactin secretion, things like dopamine antagonist or dopamine by itself, dopamine agonist like bromocriptine, possibly somatostatin, and the prolactin itself by negative feedback, which will increase the release of dopamine. And I just reminded you of this placental progesterone during pregnancy. This is not one of the classical factors that affect the prolactin secretion, because it's only there when there is a pregnancy, but it's good to remember it, because this prevents basically the synthesis of milk before delivery. I mean, we don't want it to be, it's already high, but you know, somehow it helps to reduce its level, at least at the early stages of pregnancy. Now, how it works? Okay, it acts on cytokine membrane receptor or tyrosine kinase membrane receptor. And if you remember, the prolactin itself It acts on a dimer receptor where the receptor itself does not have a kinase activity, but rather it is covalently bound with another kinase known as genus kinase. And once the prolactin binds with this receptor, it will cause phosphorylation and activation of the genus kinase, and this will lead to protein synthesis, among other things, and also it will lead to the formation of the signal transducer and activator of transcription, which is known as SAT. So it's basically the signaling pathway for prolactin is the JAK-SAT system, which we discussed in the first lecture. See, that's why you have to understand these things, because when you go and read about prolactin, you know what the JAK STAT, it's receptor-associated kinases, tyrosine receptor-associated kinases. They are associated with just another kinase or genus family or JAK. Progesterone by the placenta, as I said, interferes with the prolactin binding on the alveolar cell within the breast, thereby directly suppress milk production during pregnancy. High levels of prolactin during lactation, and as lactation continues, suppresses ovulation because it inhibits GnRH. And if you inhibit GnRH, FSH and LH are not going to be released, so there will be no spermatogenesis or no ovulation. This is particularly of importance to some women who use lactation as a method of contraception, because when the likelihood that a lactating woman for starting a new menstrual cycle or an ovarian cycle is unlikely because of the absence of GnRH, FSH, LH. That does not necessarily mean that it's 100%, but it works. جداتنا كانوا يمكن يستعملون هذا الميثود. احنا هلا في ميثود ثانية الناس بيستعملوها, بس it is worth to remember, but you have to remember it's not 100% safe. Now we go to the disorders. We have hyposecretion of prolactin. This lot of times occurs when we have pituitary infarction, especially in women after delivery or in Sheehan syndrome. We already talked about this. Or if if a woman is taking a drug that acts like a dopamine antagonist. Hypersecretion, and it could be due to hypothalamic damage and the loss of the inhibitory control by dopamine. It could be a hormone-producing pituitary adenoma. This is the most common actually, and they are usually benign. And patient with prolactinemia or hyperprolactinemia or galactorrhea, if you want to call it, elevated levels of prolactin, hyperprolactinemia, excessive secretion of milk or galactorrhea, reproductive dysfunctions, including loss of libido and amenorrhea. Amenorrhea means lack of menstruation. In the male, prolactinemia may cause infertility by causing hypogonadism due to the inhibition of GnRH by prolactin. Now, sometimes they can manage some of these patients. They can be managed by medications like using Prolactin, which is an agonist for dopamine, and antagonist for dopamine, or it could be removed surgically. Oh, I'm sorry, I said dopamine is an agonist rather than antagonist. And thus we can prevent prolactin secretion by dopamine, like drugs like Prolactin. This is a case for you to read. I'm not going to go through it. I mean, I think that's what you expect. For example, if you take a USMLE exam, they will give you a clinical vignette like this, and they will ask you a question. They don't, I mean, not all of the question, which of the following, this does that, which of the following is not true, all of the following are true, all of the following, that doesn't work. They usually bring a clinical vignette like this, a clinical case scenario, and they will ask questions about it. So why don't you read it? You get a practice for this, because for those of you who are gonna take the USMLE, they are expecting something like this. And I encourage you to read it. If you want, we can have an online session to talk about it and discuss it with together. Thank you very much.